Greetings and welcome to session 5 of the Lurie Children's Pediatric Roundtable for Sleep Medicine. My name is Chad Worley and I'm your Lurie Children's liaison for the north and northwest suburbs and north side of the city. And I am very excited today to bring you Dr. Irina Trosman. She is our interim sleep center director, and Regina Palomo, who's our manager for the Sleep Medicine Center. And they're going to talk to you guys today about pediatric sleep studies. But before we go on to them, I'm just going to encourage you to go ahead and ask questions in the chat room while they're discussing. And if there's a pertinent question during the talk, I will go ahead and ask them the question. Otherwise, we'll go ahead and ask the questions afterwards. And if we don't have a huge crowd, we'll go ahead and let you guys ask live if you choose to do so. And the session is being recorded. So I'd like to remind you that for those who have been on other sessions, that I will send you a link tomorrow when the recordings are all done from all other sessions. And I encourage you to share those with your colleagues, as this is some information that has been asked for us to provide for a long time now. So, but without any further ado, Dr. Trosman, I'll let you take it away. Thank you so much.
Good morning. Regina and I will be talking to you this morning about pediatric sleep studies, and it's very nice to see some friends in the audience, and thank you so much for tuning in. So we'll start by talking about what polysomnography procedure entails, what are the reasons for referring for a sleep study or polysomnography, how to interpret results, that could be tricky, and finally, how to refer to sleep studies specifically in our center, and a little overview of our center. We'll start by talking about how much equipment we actually use to monitor sleep studies. And from this picture, you can see it's a lot. We need to be able to distinguish wakefulness from sleep. So we need video monitoring, and we place limited amount of EEG leads. We are able to distinguish stages of sleep based on EEG activity, but remember, it's not a full EEG. We monitor eye movements to distinguish REM sleep, breathing through the nose and mouth. We monitor muscle activity so we can see if the child's muscles are relaxed or whether or not they're rhythmically vibrating due to snoring, or perhaps the child is grinding teeth. We place 2 belts across chest and abdomen to monitor breathing pattern, oxygen, EKG, leg movements, and even a little microphone to register snoring. You can imagine it's a lot. And with all of this, we expect the child to cooperate at bedtime, right? Wish us luck. Now, we also hope that the children will be able to allow us to test the equipment and make sure everything is working properly and remains working properly, and the child is tolerating it throughout the night. Well, of course, it doesn't happen most of the time. And so it requires very skilled technologists and some preparation work and support, parental support. And so it's not uncommon for us to see parents staying in the same bed with a child, because it is a challenge to tolerate all this equipment. So the study night is not always a good reflection of the child's typical pattern at home. And the reality is children frequently pull the equipment, and our technologists have to go back and adjust it. And in some cases, children breathe through their mouth rather than nose. So we're not getting any signal from the nasal passages, and that creates trouble interpreting respiratory part, which is very important. And of course, pediatric studies are very artificial. It could be because of parental movements, parental snoring, parental electronic devices usage. So it's a challenge to read the studies. And keep in mind that they are expensive. They could cost up to $2,000. And with a high deductibles, many families may find that this is very challenging to afford doing a sleep study. And one other detail, since the sleep studies required specific pediatric equipment, including carbon dioxide monitoring, which is not always accessible in smaller centers, and even those who claim they do frequently don't have transcutaneous CO2 monitoring, you're probably better off sending your patients to a skilled tertiary care center, especially if it's not a straightforward case, if you worry about the child or it's a challenging child, or you really worry about some sleep disordered breathing. Those children really should be seen in the skilled, perfectly appropriate for pediatric sleep center. And we do not use home sleep studies. You can imagine what a challenge it would be for the parent to monitor all this equipment and constantly adjust it. It's just impractical and almost impossible. So what are the indications for the sleep study? The most common indication is the diagnosis of obstructive sleep disorder at breathing, and specifically obstructive sleep apnea, as well as central sleep apnea. And that is more common in neuromuscular disorders, but we also see gas exchange abnormalities that are early manifestation of respiratory failure, especially in neuromuscular patients. So that's another reason to do sleep studies. We do sleep studies for treatment purposes, so positive pressure, airway, high flow, oxygen, and so on. There are any unusual behaviors and you would worry about that they're not typical. Perhaps you're worried about seizures and restless leg syndrome, clinical diagnosis. But if the child has symptoms suggestive of restless leg, you may want to do a sleep study to look for periodically movements, which would be a supportive diagnosis of a restless leg. And of course, excessive daytime sleepiness. Having said that, excessive daytime sleepiness may result from multiple factors, including medical conditions, medication use, inappropriate sleep schedule, irregular sleep schedule. So sleep study is not just the first answer to evaluation of excessive daytime sleepiness. What I would like to point out that insomnia is not on this list. In fact, insomnia should not be the indication for a sleep study because rarely do we find an explanation unless there are other red flags present, such as snoring or so on, so that you're worried for another condition that may be causing awakenings. But if you're really worried about snoring, about insomnia, that's not a good indication for a sleep study. How do we interpret sleep studies? It takes us to a next step. What about sleep architecture? How does it change? What is appropriate for kids so that you can take the sleep study of your particular patient in a context? And the sleep study, sleep architecture changes throughout lifespan. Overall amount of sleep changes from infancy to adolescence. There is a significant reduction in REM sleep, and there is a significant reduction in non-REM, primarily because of stage N3 sleep, which is deep sleep. Now, when we talk about sleep, we distinguish two main stages, so to speak, non-REM and REM. In non-REM, we distinguish stages in 1 and 2 and 3. Dr. Deng went very nicely over this stages yesterday. I'll just point out that breathing is very irregular in stages N1 and 2 and 3. People dream, but dreaming is not very vivid or complex. As an opposite to REM sleep, very unique stage characterized by very vivid dreaming, eye movements under eyelids, and very irregular heart rate and respiratory rate. In addition, muscles are essentially semi-paralyzed, so that breathing could be quite compromised. We really depend on our diaphragm to breathe during REM sleep as opposed to any accessory muscles. Just to give you an example, this is a 2-minute screenshot of a sleep study. On the top are eye movements in blue. You can see this kind of sharp deviations. Those are rapid eye movements that occur in spurs. Black lines on the top are brain activity, chin EMG, which is a muscle tone, snoring microphone. I'm going to skip these lines. They're kind of self-explanatory, EKG, heart rate, basically, and the oxygen level. And then we can see carbon dioxide monitoring and then nasal cannula signal that splits between nose and mouth, and the two belts that go across chest and abdomen, and the intercostal muscle effort. You can probably appreciate significant variability in depth and amplitude or breath, but no significant desaturations. This is kind of a regular breathing pattern in REM sleep. The next slide is non-REM sleep, and you can see very regular breathing pattern. Breath are pretty much uniform. This is what is normal. Now, if we look at the sleep architecture and what is overall normal for childhood, we look at the following parameters, and they're all listed under the sleep architecture in the sleep report. Sleep efficiency, how much child slept out of time in bed, how much time it took to get to sleep, sleep latency, the amount of time it took to get to REM sleep. Very short REM sleep latency could be, not always, a sign of narcolepsy. How many times the child had micro awakenings per hour. It's called an arousal index. It's normal to have up to 16. And then the distribution of sleep stages. In general, minimal amount of stage N1, a little bit more stage 2, and a pretty equal split between stage N3 and REM up to age 10, and then a little bit less stage 3 after age 10. When you're receiving results of the sleep study, I urge you to talk to the family and ask if the sleep study was a challenging night, if the sleep pattern was similar to a home sleep pattern, whether the child was very upset or crying or congested or maybe didn't feel well. Look at the sleep architecture and see if there was another sleep captured. If you only got 2 hours of sleep, the study might not reflect or find what you were looking for. And if you worry about sleep disordered breathing, definitely make sure the child got enough REM sleep. So this is a graphic summary or a hypnogram of a study night, which basically gives us the most important information about the sleep study. On the top is sleep architecture. And you can see in very small letters, so I'll walk you through, is wakefulness. So for this particular child, it took a very short time to descend to sleep. And then it looks like a staircase, a little bit of stage N1 sleep, a little bit more N2, good chunk of stage N3 sleep, brief awakening, which is normal, a first period of REM sleep. Second sleep cycle consists of mostly stage N2, brief awakening, and so on. You can see that REM sleep is occurring in intervals that are getting progressively longer. And this particular child had about 5 REM periods, and we finished the study while the child was asleep. That's a fairly good night. Underneath, there is a thin line with oxygen saturation. Green bars are brief respiratory events, in this particular case, obstructive hypopneas. And at the bottom, you can see a child's position, supine, lateral, and so on. So this is a very nice overview of a snapshot of a sleep study that gives you an idea if the child received enough, had enough sleep, what kind of sleep, and whether or not the study was interrupted while the child was asleep. And we typically finish studies between 5 and 5:30 pretty early. The next slide is the child who didn't have a very good night. You can see plenty of brief awakenings throughout the night. Only one good REM sleep period, a tiny REM sleep period over here, and the termination of the study when the child is still asleep. So this child probably didn't have a very good night, and it's good to know whether or not it's the same sleep pattern that the child experiences at home. When we look at the respiratory analysis, we look at the flow of air through nasal passages and mouth, and we're looking at subtle changes or very obvious changes because we know it's a spectrum of sleep disordered breathing, from subtle changes like in this slide where we can see flattening of waves, and the waves have very different form. So clearly there's some degree of limitation of airflow and continuous effort, but no true discrete events to call apneas and hypopneas. The next slide shows more obvious events, few normal breath, and then significant flattening, continuous effort on the part of chest and abdomen, a brief awakening that you can also consider a rescue awakening. The child is waking up to catch the breath so that he or she doesn't suffocate. Temporary increase in muscle chain associated with this brief awakening, oxygen desaturation with brief return to baseline, few rescue breath related to this rescue awakening, which allow the child to resume breathing until the child descends back to sleep. And you can see again flattening of the breath and the following brief awakening. Those are obstructive hypopneas, partial airway narrowing. More extreme case, true apneas. There's essentially flat line, no airflow through nasal passages, and essentially the same outcome. Brief awakening, resumption of breathing, desaturations, more profound in this case. So this is actually a video of a child from our sleep lab, and I'm hoping I'll be able to show it to you, where you can see the child on the right side, the video recording. And before I go over it, I'd like to show you what I'd like you to look at is the asynchronous movement, asynchrony between chest and abdomen, very noisy breathing, and a little gasp associated with brief awakening. And on the left side is basically what we were just looking at the previous slide, which is pretty significant reduction in airway flow, profound desaturation. This is a child who is actually currently admitted to our ICU and just had adenotonsillectomy yesterday for severe sleep apnea. So she was admitted from the sleep study because of this profound desaturations. This is the obstructive hypopnea. This is her brief rescue awakening associated with movements and a gasp. And then she starts breathing again, and then she has another episode. So A summary of the study or hypnogram for a child who has severe sleep apnea may look like this: very frequent awakenings, profound oxygen desaturations, mostly occurring under REM sleep, those are the green bars, and essentially a confluence of respiratory events, obstructive hypopneas in green and obstructive apneas in red. So when you receive a report from a sleep study, it may look different from different labs. In our center, we create this report where on the top, we will comment on sleep architecture. Again, we're looking at how long it took to fall asleep, how much time the child overall slept. So there would be almost 7 hours, the ratio of sleep to overall time in bed, distribution of sleep stages. And of course, we comment, so you don't have to remember all the numbers, but I think it's worth knowing what they mean. And then the respiratory analysis is at the bottom. And this particular child had severe sleep apnea, but this index, apnea-hypopnea index, is not the only indication of sleep apnea severity. In fact, if you look at the respiratory analysis, it's very important to look at the lowest oxygen level, frequency of oxygen desaturations, how much time the child spent with abnormal oxygen level, and whether or not there was elevation of carbon dioxide level, and if so, for how long. Now, I mentioned that we do sleep studies for the purpose of titration, oxygen, CPAP, high flow. Those are the studies that we reserve for patients who've been seen by our specialists. So we are not allowing outside referrals. And the reason for that is because we want to make sure the child is prepared for the study, that we use mask desensitization, and we're doing mask feeding, and we're preparing the child in training with CPAP blower, which is a unique feature to our program, because we, as far as I know, we're the only program that allows kids to practice with CPAP prior to CPAP study, so the child has the highest chance of tolerating CPAP during the study and after all. And we're also unique and the only program in our state that is lucky to have a sleep psychologist who also helps us with the most challenging cases. So this is just an example of a sleep study of a child who had CPAP titration. The first start at the very beginning, there was very profound severe sleep apnea, and then CPAP therapy started at 5, titrated to 14, and you can see the oxygen line becomes very thin, so desaturations resolve, and so is true about respiratory events. They essentially completely resolve in the second half of the study. Now, other things that we do sleep studies for, I mentioned that when we worry about parasomnias, especially unusual parasomnias, not typical parasomnias, as Dr. Deng mentioned, those don't require sleep studies. But sometimes we find abnormal brain activity. So this sharp discharges are sharp waves in a child who has abnormal EEG. Doesn't necessarily mean the child has seizures, but it could be associated with seizures. We sometimes do sleep studies for rhythmic body movements, especially if they are violent. And so this is an example of a child who presented to our sleep study. We wanted to make sure that these rhythmic movements are not caused by seizures or perhaps some respiratory events. So you can see very violent head banging that was occurring throughout the night on multiple occasions. And the next slide is a child who has pretty significant body rolling. And again, parents were very worried because it's been going on and off throughout the night. So you can see kind of rhythmic body rolling from side to side. And we do see it more often in children with developmental delays and autism, but it's not always true. Sometimes we see it in perfectly healthy kids. This is the child who was a very good, perfectly appropriate referral from one of our ENT colleagues, a very astute physician who had this child as a second opinion for suspected obstructive sleep apnea. This child has been waking up, gagging, choking, and at least 5 times a night for almost a year. And she had sleep studies done at sleep centers in the Chicago area. So this is our 3rd sleep study. And the parents were so worried that they even took her to the emergency room. And at some point were referred by their pediatrician for psychological support. So when you see this child, I will just give you a little heads up. Look at her leg movements. become kind of mechanical, very kind of bicycling movements. She gags and she arches. And because her mom was so worried and nobody seemed to believe her that this is just not a sleep apnea, that she tried to record her without realizing they were actually doing video recording. So this is the child suddenly arising from sleep. Look at her leg movements. And then she's arching, gagging, stiffening. And mom is trying to record her. So these gagging episodes were perceived by other physicians as sleep apnea, but when in fact was happening, she had frontal lobe seizures that were so profound that they were so significant that they were occurring nightly. And for a year, this child wasn't diagnosed. So she's now well treated with anti-epileptic therapy and followed by our epileptologist. So again, if you're concerned about unusual behaviors during sleep study may be very beneficial. So in conclusion, our sleep studies and any sleep studies in children are challenging because of all the challenges that I mentioned earlier and difficulty cooperating. We try to prepare families, and we have information on our website, and Regina will walk you through that. We are trying to minimize the chances of child being uncooperative by preparing the families. There are very specific indications for the sleep studies, and they don't include insomnia. So sleep studies are not always the answer to sleep problems. And good history, sleep logs, or even actigraphy could be quite helpful and bring more information to sleep studies. And when you do receive results of the sleep study, again, make sure that you put the results and interpretation in the context of this particular patient. And then we also want to make sure that the sleep studies are done in a timely fashion. So I will pass the torch to Regina so she can walk you through the process of referral in our sleep center.
Thank you, Dr. Trosman. Hello and good morning, everyone. I will be providing you with a quick overview of our sleep center and a peek at what a sleep study entails. The Lurie Children Sleep Center was first accredited by the American Academy of Sleep Medicine in 1996. Accreditation by the AASM indicates the highest standard of care and staff credentials, in addition to exceptional facility management. Our sleep center is primarily an outpatient ambulatory specialty. However, we do provide limited inpatient services through consultation and polysomnography. Next slide, please. We offer a variety of polysomnography services, such as diagnostic sleep studies, which, as Dr. Trosman mentioned, is currently the only study available for direct outside referrals. In addition, we offer a wide variety of therapeutic polysomnography, such as positive airway pressure titrations, O2 titrations, high flow, nasal cannula, and multiple sleep latency tests. We've also partnered with our pulmonary and ENT colleagues to provide outpatient sleep studies to the pulmonary habilitation population and inpatient cap trach studies. Next slide, please. Sorry. Our team consists of 4 sleep specialists, 1 behavioral sleep psychologist, and 2 advanced nurse practitioners. In addition to our amazing provider group, we have a robust pediatric sleep team, which consists of lead sleep technologists, licensed respiratory therapists, sleep tech 1 and 2, and most recently integrated sleep tech assistants. Next slide, please. In terms of our sleep studies, as Dr. Trosman mentioned earlier, a sleep study requires our patients to be connected to several sensors. Just to give you a quick overview of what the connection process looks like for a typical patient, we place 12 to 18 EEG sensors on the patient's scalp to determine if the patient is awake or asleep, and if asleep, what stage of sleep. We place 2 sensors on each leg to monitor for limb movements, 2 on the patient to monitor muscle tone, 2 sensors on the chest to monitor their heart, 2 on their intercostals to see how much effort they put into breathing, a snore microphone to monitor snoring, and lastly, we place a nasal cannula and airflow sensor to help us monitor the patient's breathing and carbon dioxide levels. The next few slides review instructions that are provided to our families at the time of scheduling and during reminder calls. I will highlight those instructions that are most pertinent to those who have joined our meeting today. Patients are asked to arrive between 6:45 and 7 p.m. and are typically discharged by 6 a.m. We make every effort to collect between 7 to 9 hours, and all studies are audio and video recorded. We ask our families to take any medications as prescribed unless otherwise specified for the sleep study. Families are responsible for administering all medications, therefore should bring any medications needed during the overnight stay. Next slide, please. Our sleep center also follows hospital-wide COVID-19 protocols, which include universal masking. And sleep studies are interpreted within 14 days. Families should reach out to the ordering provider to review those results. Our sleep medicine providers do reach out to referring providers with any emergent sleep studies results within 24 hours. And all sleep studies are made available to those families with EMR access. Next slide, please. We currently have 2 locations. Our primary sleep lab is located within our Lurie Children's main campus, located at 225 East Chicago Avenue. And our second location is within our partner Northwestern Memorial Outpatient Center in Grays Lake, which is located at 1475 East Belvedere Road. We also have listed the phone number and fax for our sleep center on the slide. So if you would like to refer a patient to our pediatric sleep center, please fax a consultation request to 312-227-6740. And for sleep study referrals, please fax a sleep study order with diagnosis, history, and patient BMI. Also instruct the family to call the sleep medicine center directly, again at 312-227-6740 for scheduling. Lurie Children's will be responsible for obtaining insurance prior authorizations as long as the above information is provided. All right, I will turn this over back to Dr. Trosman or Chad for any questions.
Thank you, guys. That was a wonderful presentation, very informative, and I think a lot of questions were already answered as you went along. It was very thorough. So, but I do encourage the audience, if you have any questions, raise your hand or type them in the chat room. But while we're waiting for that, so we have Grays Lake, we have the main campus. Can you talk a little bit about the Almost Home partnership while you have that on there?
Sure. So we started an Almost Home partnership, Almost Home Kids in Chicago and Naperville, where we provide consultation services and polysomnography at both locations.
Okay, great. So Lisa McKenna writes, for that child head banging, was he still asleep while he was banging? How was this behavior managed?
This child wasn't asleep when he was banging in this particular case, and there were multiple episodes when he was kind of transitioning to sleep, getting drowsy. How was he managed? I don't know this particular patient. A lot of times patients come to us as direct referrals, so we read the study, but we don't really know how they are managed unless they come to us for consultations. That's one of the things to keep in mind, that we're not really giving any recommendations based on the results of the sleep study unless we see the patient. So because we, again, need to put the information in the context of the child's history. Now, head banging is challenging. Now, again, sometimes just treating their underlying problem, whatever it is, it may be insomnia, it may be that they're so attached to the parents that they can never fall asleep alone, and that's their soothing mechanism to fall asleep. Anxiety, I mean, there are a variety of reasons. Sometimes we just don't know. On occasion, we use iron, because we think that head banging or any rhythmic movements are part of the sleep movement disorder. But when we say sleep, it really could be also just during both wakefulness and sleep. And some of these kids do it during wakefulness, even during daytime when they're just frustrated. So it's very challenging. And that's why we use our sleep psychologist help in partnership with child's primary care and any other developmental and behavioral peds to look at the picture overall and see what's going on during daytime. And then obviously sleep reflects these behaviors as well.
Great, thank you for that. Another question was, what is the youngest age for a sleep study?
None. We do it as early as babies are born in the NICU. We try not to do it in extreme preemies just because their brain landmarks are not developed yet. But any full-term baby or near term, we do sleep studies, so there is no age limit, even for outpatient sleep studies too. Okay, in our lab, other labs may have different cutoffs.
So with that, so when you have a newborn, and what would be some of the signs that make you say, hey, we need to see this baby, we need to do a sleep study right away? This, this baby's 1 month old. What would be behind that?
So we get such referrals from our ENT and neurosurgery colleagues, mostly because of the breathing issues. And sometimes if the baby turns blue or stops breathing, we're worried whether or not there was a seizure or perhaps some respiratory events. And neurosurgeons frequently do it for spinal dysrhythmism or a spina bifida. They're worried that this child may have central apneas. So any breathing issues in an infant, especially when they occur specifically during sleep, they usually prompt sleep studies in addition to overall thorough evaluation. So
Sure.
they rarely come directly from primary care. Most of these kids end up seeing subspecialists first, even urgently, and then come to us.
Great. You brought up ENT just now, and since we don't have any other questions, what I'd like for you to do is, can you give us a little bit of a tease what we can expect for 12:30 this afternoon for our audience here?
Yes, of course. I'm very fortunate to be joined by two of my ENT colleagues who will be talking about their approach to treatment of sleep apnea. And this dialogue will be a true reflection of our working partnership. We really work closely with our ENT colleagues in hoping to build a multidisciplinary clinic when we're actually in the same space physically, not just doing video as we from time to time do now. So I think this is kind of a piloting of our potential multidisciplinary clinic, and I think we'll give an idea how this partnership works.
Well, we're very excited about it. I know our audience is excited about it too this afternoon. So, but it looks like we don't have any other questions. And so first, Regina, thank you for joining us today and for bringing us through what goes on over at the Sleep Center. So thank you for that. And Dr. Trosman, thank you for your presentation today, and we really look forward to seeing you later on for session 6. So without further ado, thank you, audience, for joining us today. Recordings for this will go out tomorrow, and I look forward to seeing you at 12:30 this afternoon. Everybody have a great day and take care.
Awesome. Thank you.
Thank you, Chad.